Hello, dear colleagues. Hello, dear listeners. I'll start the webinar with a logistical point. This meeting today will be in 3 languages: Armenian, English, and Russian. And for you to select the language, please click on the globe. Then you can then listen to the webinar in the language that you prefer. I'm glad to welcome you today. We're conducting a webinar as a part of our series of meetings for palliative care professionals. This meeting today is dedicated to identifying and developing palliative care in Armenia. And with our distinguished lecturers, we will try to see this process from different angles through the eyes of professionals with different specializations. We'll discuss the existing difficulties and the future plans. Allow me to say a few words on the PASTE Foundation. Yeolyana, I represent the Foundation for Palliative Care Education. PASTE, we're a charitable fund created in 2018. We work in countries of the Caucasus, Central Asia, Eastern Europe, and the Baltics. We support palliative care specialists in obtaining professional knowledge and developing their experience. You will now see the link to our website. There in the publications section, you may become familiar with our latest materials, with our digest, the history of the webinars we conducted. And to stay in touch with us, we invite you to sign up for our newsletter. All the news emerges there. Also be done at the bottom where there is a form in our website. Right now, for instance, we're preparing a new online course for medical specialists in palliative care. And we will try to cover the hardest and perhaps largest number of topics, such as controlling the complications, syndromes, respiratory support, care measures. And if you have any experience and if you have expertise in this field, we invite you to cooperate. And if you feel that you have the power to act as a lecturer in our events, please do contact us and we'll be happy to discuss it. We also have a Telegram chat for specialists from the countries and the regions which I enumerated, which we also regularly conduct. The very first thing that emerges there is the news that we would like to share with our distinguished colleagues. We also invite you to join it in the chat of the webinar. You will now see the link to a very simple Google form. Let me remind you, that's one where we can add you to. We can add you to that chat there. You will always get our news and you will always be able to pose questions based on your experience of difficult situations and discuss with colleagues and get qualified feedback. Once again, for those listeners who are joining us a bit late, this webinar is conducted in 3 languages: Armenian, English, and Russian. And to select the convenient language, please click on the globe at the bottom panel of Zoom. We have with us a team of simultaneous interpreters. I'll introduce them. Khachatura Dumyan, Shushanik Agababyan, Tamara Kalantaryan, and Gevorkyan. Thank you very much. In the second part of today's webinar, you will have an opportunity to ask questions to our distinguished speakers, but I urge you to write questions during the speeches so you don't forget them, and then we can revert to them right after the presentations by the speakers. Allow me now to introduce to you our distinguished lecturers of the day. Narine Movsesyan, anesthesiologist, professor at Yerevan State Medical University, palliative care and pain management specialist, international leader in the palliative care initiative. Eva Movsesyan, coordinator of health program development programs for children and adolescents in the Arab-Gir Medical Center, and director of the Association of Armenia's Pediatricians. Esther Demirchyan, director of the City of Smile Fund. Anush Sargsyan, pediatrician-rehabilitation specialist in charge of children's palliative care center in the Hematology Center, named after Professor Yeolyana. Alisa, Kamalyan, child psychologist in the Hematology Center, named after Professor Yeolyana. And Tigran Buzantian, thoracic surgeon, director of the palliative care surgery in the National Oncology Center, named after Panarjan. Hello, I'm ready to give you the floor. You can show your presentation on the screen now. I'm sorry, Narine, but it's not full screen right now. Can you fix that, please?
Отлично, спасибо. Передаю вам слово, спасибо.
Excellent, thank you. I give you the floor. Thank you. Hello to your colleagues. First of all, I wish to thank PASTE. For a long time, we've been cooperating with them. Over time, coming closer and gaining time when the leadership in PASTE was changed. Anyway, I'm very glad that we're now kickstarting our new cooperation. This is a very nice and extensive initiative by PASTE. I also want to thank the people who organized this event and are enabling us to present to you our activity, which we have carried out for quite some time now. And allow me to tell you a bit about it and how it's taken place. It all began a very long time ago. Here's the journey. We started right back, way back there, with that journey where we just started slowly and slowly climbing up. It all began in 2003, when Hrant Karapetyan, for the first time, approved the pain control and palliative care, or he's established the pain control and palliative care PC association. Most of the members were oncologists. And one day, in a private conversation, Hrant Karapetyan shared with me, because we were colleagues, he said, you know, I've had this initiative and invited to work together. For 21 years now, we're in this journey. We're still right around here, and we still have quite a ways to go. But I don't know how much time and effort we still need to make to be able to prevail or achieve or reach the peak. We can see the peak, the summit yet. Speaking of our achievements and what they are, gradually, seems like by changing the medical community's ideas and promoting the narrative, and that's a trendy word, narrative. The narrative about palliative care, we got to the point where with a group of colleagues, not just Karapetyan and myself, but there were a number of other people who were helping all of this. And in 2008, on March 27, it was decided to introduce palliative care for adults as a part of the medical care and services list. So that was the first time it was introduced into the medical community. Able to do all that, in 2010, we understood that we don't know how much it takes, what we need to do, and how we need to do. And the health ministry gave us the possibility, and we were coordinated by our very good friend, Stephen Connor, who is an International Palliative Care Alliance's director, and enabled us, with us, carried out the needs assessment, and that assessment enabled us then to understand, to make up our minds, and to see what we need, where we need to start, and where we need to go. In 2011, understanding that we cannot just go on without any education and do this work, we decided that, when I say we decided, it includes a group of professionals who were helping us and who themselves were working to create these programs. And for the first time, we invited the current L1 courses, which for 60 doctors and nurses, to create a certain human resource foundation so we can promote the profession. And for all that, we were supported, and our sponsor was the Global Fund, which enabled us not just to get educated, but also to carry out a pilot program. And 4 pilot programs were introduced, one in UAC, the other one in the Medical University, and 2 were introduced in the regions, one in Ararat, and the other one was created in Vanadzor. For 2 years, we tried to understand what needs we had, what we had to do, who had to participate, how much the cost would be, how it could be delivered, for the government, the states, and the government to understand and to start the process and to promote the process of palliative care in our developments. In 2012, the healthcare ministry, a national health policy working group was created to develop real mechanisms. So we already had a certain understanding, and we needed somehow to reflect it in certain documents. And it was the Armenian government's approval to the palliative care concept. The concept was there already for Armenia, and palliative care concept was introduced, and the standards and activities would be possible. Parallel to this, of course, there were a number of processes being limited, having a great heritage of the Soviet legacy regarding opioids, where opioids were not prescribed or not enough were prescribed. We decided that we need to educate society, and the medical community had to be educated as well. And for that, the health ministry adopted a decree approving methadone as the main, in the list of the main painkillers for methadone. We had prior to that the harm reduction approach. We had the substitution methadone program as a registered program, and for that, methadone was accessible to us, and on 2 sites, in 2 places. as part of the palliative has been used. And then the Life Without Pain 3-year campaign was introduced. And we had roundtables, lots of roundtables. And it was on different platforms, always advocated for palliative care. And in 2013, the NGO called Real World, Real People launched a legal clinic. What that meant was, and I was their specialist, their expert. I was involved, and when they were discovering people, and people were approaching them who were suffering from pain or cancer pain or other pain, and the organization would refer them to me, and we would try to understand whether the patient was receiving any pain relief or not. It was mostly for legal problems, so it was called the legal clinic in the field with the doctors in cooperation with the patients. We were taking care of it. And to be more accessible and more to the people, we developed something visual to make it very clear to the public. We called it the torture chair. As you know, this torture chair was very common in the Middle Ages. I think the Jesuits were using it to torture people, to extract the truth or something. So we ordered one of our masters in this process to make this chair when we ordered the chair. And this is obviously a very tough mechanism, but we made something similar, and here's the chair. And it was in the northern avenue of Yerevan, and we were there, and we suggested to random people to sit and to feel how you're tortured if you have pain and you have no way to get any pain relief. And it was quite illustrative, and you can see on the background the pictures of patients and the street flash mobs or the campaigns showing that there were patients that were suffering from these situations. From 2014, with the government decree, palliative care now became a medical profession in Armenia. I know that many professions do not even have that profession. In Sweden, they don't have that profession. The service is there, but there's no special profession. But if there's the profession, then there must be also standards approved in 2014 in decree, in the decree approving palliative care standards and the law. So for this whole thing, the only thing wasn't covered was children's palliative care, which is quite specific. I won't focus on it. We have good professionals who are doing this for the first time. In 2016, the job descriptions were approved, meaning what should be done besides the standards. What is the job of the doctor and the nurse? With all of this, we were thinking about human resource problems. New people were always coming in, and they were supposed to get the appropriate education for that reason. For that purpose, I mean, 60-hour required course, mandatory course, was developed for the family physicians and clinical residents, so as to understand to what extent the PHC physicians can handle this. And we saw the impact, because especially the family physicians who were the first, or the primary healthcare physicians who were the first to encounter, really need to understand when in their medical intervention, when their medical intervention can become palliative, and where that line is. The line beyond which they have to change their perspective. For that reason, also, a course was developed on palliative care, was introduced as a subspecialty. So we have different courses. In different courses, we have a sub-course. 1,295 hours of courses were developed, including 400 hours of theory and 895 hours of practical training, bedside training. Was developed, is still being done. We have this now. We have current students. Besides, in 2016, Yerevan State Medical University's clinical psychology chair developed a course on palliative care. And so our numbers grew. We know that it's multidisciplinary teamwork. We had the doctors, the nurses, and also the official psychologist added. An Armenian Pediatrics Association developed for the practical training. I won't focus much on pediatric care, sorry, because we're focusing on more of a precise approach. So what are the challenges? I've spoken about the achievements. You may think, oh, so much has been done. Look, they don't have any problems. Yes, we do. Yes, we do, because we have, I'll tell you, we've brought in all the regions, all the Marses, again, with the NGO called Real World, Real People. We went to all of Armenia's regions and we conducted trainings on palliative care, but still, we have major problems of opioid prescription. According to official Armenian statistics by Armstat, we have this problem based on mortality due to malignant tumors. The annual number was calculated. It's 25.74 kilograms of opioids, of which pure substance is only 19.56 kilograms. So that's roughly 20 kilos for the whole country based on the patients, but still huge resistance. And here's the picture. When it's just pain relief of 6% and the 94% just receive not sufficient pain relief, this remains a major problem for us. That's why, in addition to reading, in addition to educating the doctors, we keep monitoring them also to see whether anything has changed. If people do not imagine this, that what is behind these numbers, I say, think of it. Imagine that among 100 patients, only 6 are getting pain relief and 94 are not. The challenges, we need a change of the mindset. That's the main difficulty, always changing the mindset. But we did a lot of work and we changed a lot, especially now with the new generation being more resistant to new knowledge. The commercialization of palliative care, in part because of a lot of private hospices, which aren't really hospices, but then there's no other possibility. That is a sort of a possibility to look after these patients. We have one official one in UAC. We have the National Hospice, which has 30 beds. It's in the National Oncology Center Institute. And the third challenge lack of audit and accountability. And this is the most daunting problem because if you come and change something, you need to then follow up. Okay, so we monitor, we go there, but then really don't have much capacity to influence it without audit. The problems of teamwork, this is a cultural aspect characteristic of the Armenian version of palliative care. There's also a lack of that teamwork due to the Soviet legacy, but we know nobody can do this alone. Anyway, this is being overcome, and it would be good to make this mass, to popularize this. Maslow pyramid here. Because look, I mean, we keep complaining that, oh, why are we not making enough progress? Why are we not able to achieve anything quickly? Well, let's understand that we are in a difficult situation where we're constantly doing these two levels. We're unable to elevate, to climb up. But we're en route, we're slowly starting that journey, and we'll be getting to that love and belonging and esteem where life quality is appreciated, human life quality. So as not to be on a downside, we have now quite a serious option. We have the refreshed Maslow, or the first level is Wi-Fi. But there's a big message here because technical capacity enables us, gives us a lot of capacity to achieve, to get there much more quickly. But still, one of the big achievements is 32 services. Good or bad, 32 services. In Yerevan and in the regions, we have them for palliative care, either offices, cabinets, or inpatient, palliative inpatient. And there's a hospice, and there's another one in Massis also. Thank you. That concludes my presentation.
Нарине, большое вам
Narine,
спасибо.
thank you very much. We appreciate the very nicely redone Maslow pyramid. That's a very good version. It's hard to disagree with it, actually. Narine, then I'll give the floor to your colleague, Eva Movsesyan. Let me remind you, she was the coordinator of child health, and adolescent health and development programs at the Arab Medical Center and director of the Armenian Pediatric Association. Eva, hi. Hi, dear colleagues. After my colleague, I'll speak about pediatric palliative care introduction and development journey and the development prospects. And of course, we need to say that pediatric palliative care is more complex, more challenging, and specialists would agree that in reality, it's different from adult palliative care, and we genuinely still need to cross a long journey to fulfill. Do you see my screen? Do you see my presentation? Yes, it's all good. We see it. Thank you. Thank you. And so, the first steps that we took. At first, we had the initiatives by specific NGOs, projects implemented with the help of international partners and donors. And the first needs assessment among the child population was carried out in Yerevan, the capital city, back in 2010. And about 300 patients were discovered, who mostly had neuromuscular, genetic diseases, CNS disorders, and so on. At that time, the first pilot service was created based on the Murat San University and the Yerevan State Medical University, where there was a pilot team comprising a pediatrician who was also a PP, palliative care specialist, a psychologist, doing also the performing functions of the social worker, the kinesiotherapist, and the volunteers. Let me start off by saying, for those people who are not so closely familiar with the palliative care needs, that in the pediatric palliative care, we have a very small percentage of onco diseases and a much higher percentage of various neuropathologies and neuromuscular diseases and congenital disorders and metabolic and chromosome disorders, and the needs are really quite extensive. And without the engagement of the therapists, it would be hard to imagine quality services. And at that time, services were introduced, pilot services, for about 50 families. And at that time, the first pediatric palliative seminars were conducted, and medical staff and volunteers were trained. The first comprehensive needs assessment countrywide was carried out by the Armenian Association of Pediatricians, Armenian Pediatric Association, the same international expert that Narine mentioned, and using international methodology in two areas. There was needs assessment. Firstly, child mortality and morbidity data, based on which certain ratios were applied for certain categories of diseases, the causes of mortality, and using official statistics as well as data from specialized centers. And that methodology was developed on the basis of estimations by WHO's Department of Health Statistics and Informatics. This second part of the assessment was the actual surveys and focus group discussions and interviews, and through a special standardized questionnaire, mostly targeting the medical organizations, which had medical as well as social care institutions. So the places where the beneficiaries mostly were, meaning the children who were ill and who were in need of palliative care. And of course, also the NGOs became involved. So we got the assessment of the 6 main domains, which enabled us to assess the palliative care prevalence, the existence of certain elements, symptom and pain management, psychosocial support and care, end-of-life care, bereavement care, ethical issues, and human rights and child rights perspectives, legal gaps and problems. So we got to see, good or bad, much or less, the symptoms were being managed for the ill children, and then they got the highest scores. But then things were much worse in terms of the bereavement care and psychosocial support, the ethical aspects, and the legal aspects. And of course, lots of problems. Care providers, the healthcare practitioners brought up many issues related to improper or incorrect perceptions of the needs for pediatric palliative care, the absence of evidence-based guidelines, and financial problems and care organization problems, psychological issues in the families were not being addressed, and so on, but lots of issues. As to the quantitative estimates, annual pediatric palliative care need was estimated to be around 3,000, 3,300 patients. The largest group of patients were due to endocrinic and cardiovascular diseases, congenital abnormalities and defects were next, followed by cardiovascular, perinatal pathologies, and so on. So certain areas came up for us as our potential targets that we need to adopt for developing these services in Armenia. Firstly, the policy and the legislation, financial issues, and advocacy to get dedicated state budget line financing. Of course, human resources, development of human resources and services for providing the services and for the evaluation, the monitoring, and change of our policies. What success did we have? The first PPC extensive training courses were conducted in 2016, 2017. An international expert came to Armenia. TOT was carried out led by Anna Karchikova, and then after that, all the large healthcare providers which had these children or the staff of these institutions, and multidisciplinary program was developed. We brought in the nurses, the psychologists, the therapists, the social workers, and a great success was that we were able to introduce palliative care for the pre-diploma and post-diploma curriculum for the pediatricians in the ordinature programs and for the nurses. And a lot of handbooks were developed for all professionals. We also addressed perinatal palliative care, which is quite specific. It's a challenging area, and it has to do with detecting complex disorders and maintaining or interrupting pregnancies in those situations. Care for newborns with serious problems, and there we had a survey and discussions with the sector specialists. Lots of problems. Again, the lack of guidelines, change of knowledge, change of mindsets for the personnel as well as the families. And the fact that we did not have, at the time, we did not have psychosocial services in the maternity hospitals and the number of pediatric hospitals. And again, an education module was created. A roundtable was organized to discuss perinatal and generally palliative care development prospects, to inform the population and the specialists. Brief campaigns were organized and a film was created. And some steps were taken in that direction. And here are the photos from our courses, which were very successful. Here's our achievements in terms of the legal framework and policies in 2016. When we conducted the assessment, a concept paper was created, which was approved by the Health Ministry as well as the Labor and Social Affairs Ministry. And the creation and development of palliative care services were the first time was reflected in the National Strategy for Children for 2016-2020. In 2018, there were changes in the licensing conditions by the government, and the appropriate requirements were introduced with the qualifiers for the personnel for pediatric palliative care, inpatient as well as outpatient and mobile services. For 2021-2026, in the Greater Governmental Strategy and Action Plan, the idea was added that we need pilots, outpatient, mobile, pediatric palliative care service creation, which of course required allocations from the state budget. Going back, that service, the mobile outpatient service, is the most cost efficient and child rights friendly model, which is found around the globe. Of course, experts are well aware. And in 2022, the new concept was approved with the Health Ministry. 2023, an order of the MOH approved the functions and the organization of outpatient mobile PPC service, how to organize it, how to deliver it, how to detect the patients, and so on. And finally, turning to the creation of the actual services, the first service was created in 2021 for oncohematology patients with 5 beds. My colleague will elaborate on the details of that service. Next up, 3 beds were set up in the IC therapy unit of Arapkir Medical Center with life-limiting conditions, for children with life-limiting conditions. Arapkir is a multidisciplinary hospital with thousands of cases of children that need serious palliative care each year. And the mobile outpatient service was created, again, as part of the Arapkir Medical Center. But then, as I said, it would be a mobile service, and it will serve Yerevan, the capital city, and the radius of 30 kilometers nearby regions. The licensing of is in process, is underway. We'll soon get the license, and we'll start launching these services. What is our model, our vision for Armenia, and what steps need to be taken to develop the services? On the primary healthcare level, all practitioners need to know and understand what palliative care is, basic knowledge of the elements of palliative care to detect the patients and identify the patient needs and provide care and refer patients correctly. On the secondary level, there can be palliative cabinets, offices, child development and rehabilitation centers, as I said. We have a lot of combined problems in terms of the rehabilitation of child patients and in palliative care, and the difficult neuromuscular disorders in children with those disorders, CNS, children with CNS problems, perinatal pathologies that do not have potential of recovery. Or rather, the rehabilitation services would not help them much. They're going to be among the top targets for palliative care. And the third tertiary level, The larger medical centers, as well as the social care institutions, where we can have specialized services that would work on a team with a team-based approach, engaging specialists as needed. Also carry out organizational methodological functions, maintain and compile a patient register, to have a database, to carry out education programs, and of course to cooperate with all the other agencies. Of course, the first one here is the Ministry of Labor and Social Affairs. There's a lot of issues overlap. Some of the children are in social care institutions currently. Unfortunately, that's the case. They're not in the families. They need appropriate care and help in those centers. Of course, the engagement of NGOs is very important. The clergy, we think, can also be an important unit, and they need to be engaged in the palliative care activities. NGOs, volunteers, engagement. By the way, that should be done on the institutional level. There's still lots of problems in our field. We still have gaps in terms of the legal framework and legal gaps.
And rehabilitation and related to these issues. There are still unresolved issues. Of course, we are still lacking trained specialists. We're facing problems with funding, lack of essential medicines and care supplies, medical equipment, and not all mechanisms are clear to us how to ensure it within the state budget. Unfortunately, our budget is really limited. And of course, close cooperation with the Ministry of Social Affairs and NGOs, donors is important, etc. Of course, we are now facing these problems. The newly established mobile outpatient service should be operational. This is a pilot. I'd like to repeat this so that we see how everything is working, what our problems are, what our gaps are, after which we'll be able to introduce those services countrywide. Of course, the patient registry is important. And once again, I'd like to mention a change of attitude, training of specialists in the society so that we succeed. This is it. Thank you. Thank you for your attention. Thank you, Eva, for a very interesting presentation. You presented how the child palliative care is being developed. There are a lot of questions in chat. We will address them once our speakers are done. And I'd like to give the floor to Anush Sargsyan. Anush is a pediatrician-rehabilitologist. She is in charge of the child department of palliative care in the Hematology Center after Professor Yeolyana. Anush, the floor is yours. Dear colleagues, I'm very happy that we can be exposed to other countries' experience, and we will present our experience. Of course, my colleagues presented our efforts, our steps that we've been trying to make in the palliative care, both for children and adults, and we already see some results. As a pediatrician and rehabilitologist, I've communicated a lot with children and families in need of palliative care. And I have an idea on how many gaps there are in this sector. Back in 2021, when an opportunity was created and the first palliative care clinic was opened, this was a big achievement indeed for our region, because this was created for the entire region. It is a palliative care clinic under a hospital where oncological and hematological issues patients are taken care of. So this is under the oncology and hematology. It is in the premises of the Oncology and Hematology Center by Professor Yeolyana. As an expert in palliative care, I also participate in the palliative care department activities. I'd like to introduce our team. The unit has 5 beds. The calculations were made with international experts. We are on how many beds are required. So the decision was made to have 5 beds in place. These are for children with cancer only. So no other children with palliative care needs are admitted to this unit. Our main purpose is pain management. We have Auramorph. It is really comfortable and accessible because even small doses can be administered to little children. We have morphine hydrochloride in ampoules, which is used less frequently. So basic symptoms management, psychosocial support. Our psychosocial team is supporting the children and families during the treatment. They're also part of our unit. Support after the loss and home services. We say informal because our colleague Eva told it is in progress. Sometimes there are children who are from remote areas or are unable to visit, or the symptoms are manageable at home because home is the most comfortable place for a child. So it's either me or our nurse or a member of the psychosocial team visit them at home. Our team consists of a doctor, it's me, a head nurse, nurses on duty, psychosocial team, physical therapist, and a priest. It was really hard to choose nurses. The unit was opened 2.5 years ago, and the composition was changed almost 90%. We were able to find people who have a better understanding and can work better. You see, we've selected green and blue scrubs so that if the children have bleeding or something else, it's not that much visible and stressful for children. We have a physical therapist who is visiting twice a week for certain exercises. There are children who stay in bed. The psychosocial team also provides training to other doctors and the sanitary staff on how to change a position of a child, etc. And our priest, we have one main person who visits frequently when the children are in treatment. He knows them. So when they are in our unit, the same priest is attending. We, of course, always ask the parent or the child if they want to meet a priest and if they would like him to come into their ward. A couple of pictures from our unit. There are 5 large rooms. 26 to 30 square meters, where the entire family can stay. We have 4-member, 5-member families that were able to be in the room with their child. There is no quarantine. If there were quarantine situations or COVID. But in general, there are no restrictions if a family wants their relative, their family member to visit. The rooms are separate, so each child gets a room. We have a big playing hall downstairs where events are organized, or if they have guests, they may see them there. We have a big room for the children. We have a canteen. Parents don't cook. City of Smile, together with the hospital, is providing 4 meals a day, and there is an opportunity. They just can heat the meals in the kitchen. We are often asked when we start palliative care. Our unit was opened in 2021. Before that, these children were either staying in the hospital or going home to spend their last day at home. There was no service provided then. That's why this is a big achievement. So far, we've had 23 children with different diagnoses, and a couple of them were receiving home visits. The basic diagnoses are mostly oncological, neuroblastoma, and other types. Our routine, there are just pictures representing our routine. Although it is a palliative care department, I think we can make their routine interesting. You see here the nurse is playing chess with a child while the child is in a wheelchair. Everything is organized by the psychosocial team as well. It's not only the palliative care staff. They are celebrating birthdays. They have some movie heroes, movie protagonists visiting. For those who can, we have an amusement park, Yerevan Park. They can visit, or they are playing in our yard. They are trying to support each other. Parents, different children's parents are trying to support each other. We're trying to do the children's wishes as much as possible. One of them was asking for a notebook. Another was asking for a little chicken to play with. So the chicken died the same day as the child died. You here see the physical therapy process. We don't have a specialized room, but we have certain devices, equipment, and the children can do exercises in their room. Another child asked for a cat. This was organized. Another child was dreaming of going to an Italian restaurant. This was organized as well. Other activities, other support activities by the psychosocial team and other processes will be presented by my colleague. Thank you. Thank you very much, Anush. It was a pleasure to see the pictures from your unit and the children who are full of life there because of your careful attitude. Thank you very much for your attitude. Anush, I'd like to give the floor to your colleague, Alisa Kamalyan. Alisa is a child psychologist. She also works at the Hematology Center after Professor Yeolyana. Alisa, the floor is yours. Good afternoon, everyone. Thank you for this opportunity to talk about this important topic. I'm Alisa. I'm the head of the Psychosocial Service of Hematology and Oncology Center after Dr. Yeolyana. Let's discuss together the concept. As we know, the purpose of palliative care is to improve the life quality, and it includes psychosocial well-being. In the multidisciplinary team, the psychosocial team engagement is really important. I think it's useless to substantiate the importance of the psychosocial activities, but let's remember about the total pain concept, according to which not only physical pain should be taken care of, but psychological, social, and spiritual. A reduction of one of them can contribute to a reduction of another one. The psychosocial levels are different in palliative care. On one hand, it's important to have a psychologist in the team, but especially in palliative care, it is important that all members of the team have certain psychological knowledge and are able to communicate properly with the families. In this scheme, you see that in the lower part, empathic communication and general psychological support should be provided by the entire team, while the neuropsychological interventions should be provided by mental health specialists. So this four-pillar model was adopted by the European Association for Palliative Care. Of course, there cannot be support without education. Palliative psychology to fill the gap of palliative psychology in Armenia in 2016 by Applied Psychological Center of Yerevan University, led by David Demirchyan. A multidiscipline palliative psychology course was developed, 60 academic hours, and the methodology guideline was developed for this course. This discipline is included in the master's degree of clinical psychology of Yerevan State University. Then in 2017 and 2018, psychological practical training for a palliative expert was developed with 168 academic hours. Both doctors and mental health specialists were included. And in 2018, the palliative care master's degree curriculum was developed. It is still in progress. Let's now talk about clinical practice a bit. In 2019, the child oncological centers were merged, and the child cancer and blood disease center was established. The psychosocial service was also established. It is providing services in all units in hematology, oncology, transplantology, cancer survivors clinics, meaning all clinics that exist in our center. In 2021, with the support of City of Smile, the palliative care clinic was established in the Hematology Center, and starting from this year, our services cover children in the palliative care department as well. This is the specifics of our unit in the palliative care context, because the children who get treatment and care in the palliative care department recognize the psychosocial unit, psychosocial team members. They were getting their support from the very beginning, from the time the diagnosis was confirmed. This is a contributing factor so that the so-called transition to palliative care is smoother and children are easily adapted. In the palliative care department, the psychological work covers parents, children, in some case, siblings. Because in case of a child equals to family. The family, we focus mostly on the entire family. All methods that can be used for children in palliative care are being used. Here in the pictures, you see some art therapy instances. Psychological care in the palliative care unit continues after the loss as well, in the bereavement support stage. It is done based on the needs assessment of the parents and, of course, based on their wishes. The activities are both individual, and in 2023, we started group work in the bereavement stage, which was due to our good friend, one of the priests who is visiting our center. In these pictures, you can see another ritual. These are flying lanterns ritual, which is implemented, which is done after the loss, together with the parents and the health staff. Everyone knows that rituals are really important in the context of overcoming the bereavement. So this is really supportive both for the parents and the health staff. I'd like to end my speech with this. Of course, different interventions, psychological interventions, activities are important. But there is one thing that is important to me and my colleagues. This is a complete presence with the patient. It may seem easy, but my clinical colleagues will confirm that it is not that easy, and our purpose is to ensure presence at all times by our emotions, our thoughts, our stability, and our ability to keep the balance. In this case, we can support the family. Of course, to ensure this presence, it's important to ensure self-care. From the psychological perspective, I think it's good to finish here. To be able to care for the patients, we need to care for ourselves. In the picture, you see our psychosocial team. I specifically chose a picture where everyone is happy, everyone is smiling. Despite the hard work, we're trying to ensure a positive atmosphere at all times. Thank you. Thank you very much, Alisa. it's important that you're focused on the self-care of specialists. I think palliative care and in general in the medical community, it's a widespread problem because very often specialists burn out and start suffering from losses they face during their work. So the importance of this aspect and working that way is important. I'd like to give the floor to Esther Demirchyan. Esther represents the City of Smile Foundation and Geo. Esther, the floor is yours. Good afternoon. I'm very happy to be here. As it was mentioned already, our foundation is supporting the treatment of children with cancer in Armenia. We're trying to cover the entire cycle for the families that have to incur out-of-pocket expenses as well. So we're doing our best that the families don't need to spend anything. For a long time, Armenia did not have a palliative care center for children with cancer. This was my first experience of witnessing a palliative care center was in St. Jude Center, where I saw the care, the attitude, everything that was being done for the children in need of palliative care. So this may not be a very good expression, but I really felt bad about our children who did not have this opportunity. Unfortunately, there were a lot of awful stories about children who needed palliative care and their children couldn't afford even the basic pain management medicines because they lived in remote regions. In the regions, the regional clinics did not have anything to provide, so there were really terrible stories. And so our goal became establishment of a palliative care for child cancer and ensure quality of life for the children who go through this. Everyone understands this is not for the children only, this is for their parents as well, because every parent wants to see that everything possible is being done. The pain management is there, and parents themselves need support. Everyone understands that our apartments are not always adapted to children with those problems. Our system is not adapted. There are a lot of buildings with no elevators. The bathrooms are not accessible if the children have mobility problems, let alone when children have siblings living in the same apartment. It's not always good to share all those scenes and problems with other siblings because you always want the siblings to remember their brothers or sisters healthy, happy, without these last problems. So it was decided to establish a children palliative care cancer palliative care center, which should be very different from what we have. So any child coming to the palliative care should not think they are in a hospital. Of course, the approaches are different on what is allowed. Actually, everything is allowed. I mean, visitors, visiting hours, which is, of course, different from a hospital. With the support of our colleagues from St. Jude and with their advice, we initiated the establishment of a palliative care center in Armenia. Unfortunately, it got delayed a little bit because of COVID and the war in Armenia. Unfortunately, our project got delayed, but in 2021, we were able to open it. About 20 children already use the services and support of our palliative care. There are 5 rooms. Of course, we would like that all those rooms are empty at all times, but unfortunately, this is not the case. And I think the center serves a very important purpose. We've heard many reactions, responses from the families, the relatives, that they didn't know what they would do if they had to go home with the children, how they were supposed to take care, how they were supposed to ensure relevant care. The fact that very different people representing different sectors work in our center, meaning the psychosocial team and the palliative care specialists. Parents feel more comfortable knowing that their children are taken care of by relevant specialists. The parents are not carrying the entire burden, and they just have to stay close to their child and provide such psychological support as much as possible. As I mentioned, we try to establish the center in a way that children don't feel in a hospital, but think they are in a very beautiful, pleasant place where they can spend time with their family, with there were young boys, their friends were visiting. There is no restriction, so that the children are at least emotionally stronger. Of course, it's important that they don't feel lonely, which is important at this stage. This was our basic initiative. Naturally, we are continuing to support the current needs. We are providing meals to all children in palliative care and all children in hospital. We work with the medical staff if they need something. Of course, our foundation tries to support and ensure those needs are met. This is it. If there are questions, I will be happy to answer. Thank you very much, Esther. Before addressing the questions, we already have questions in the chat. If someone from the audience would like to ask a question, please press reactions. There is a hand sign on Zoom. We will notice it and switch your microphone on. Before coming to our questions, I'd like to thank our speakers once again. Thank you for your time. Thank you for this comprehensive presentation about the palliative care in Armenia and its current state, for talking about the complications and difficulties, the challenges you are facing. I'm sure we have many challenges and problems in common with our audience. I'd like to remind everyone that in some time after our webinar, we are going to publish the materials with the video in 3 languages. also the transcripts of all speakers' presentations. Not to miss it, I would recommend that you subscribe the social media pages of Paste Foundation. I think we are on all social media networks, in Facebook, Instagram. We have YouTube, we have LinkedIn. Please subscribe and you will see our publications with the materials of today's webinar. Let's now move on to the questions in the chat. I will be asking them in a detailed way. I think the first question is to Narine.
Наш слушатель спрашивает, и я абсолютно согласна. У вас в Армении
The participant is asking, there is a good legal base in Armenia. From other countries' experiences, we often hear that first, it was a working initiative established, then in some time, in some years, the legislative basis for it is being created, but in Armenia, it was established earlier. Maybe it will need further development, but based on the materials that I've seen, I think it's rather well formulated. You have the profession of a palliative care doctor. The question is about how did you cooperate with the legislative structures, with the legal structures to create the legislative base very quickly? How did you succeed in the government relationships? Do you have any secrets to share? I'll speak in Russian. Our situation is unique here because the entire legislative basis that we have, I can't tell it is perfect, but it is any palliative care initiative because everything is there already. We got funding from the Global Fund. Of course, I'd like to note the cooperation with the Ministry of Health. It was rather open. It was favoring so-called us. The current rector of the medical university used to be Minister of Health, and the current minister, everyone was really open to a huge number of people were involved, and everyone was working to advance the law. A working group had sessions 2 times. Once it was a working group under the Ministry of Health in 2010. The second time it was in 2014. We were involved in the process. We were developing it, making a more adaptable, more comfortable version. The best lawyers, public health professionals, best doctors were members of this working group. Everything was processed, developed in cooperation with the Ministry of Health. We had a really good curator, Stephen Warner, who helped us. He guided us, and we wrote everything in cooperation with him. Since my time was restricted, that's why I presented in a more comprehensive, in a short but comprehensive way. We have one of the best legislative bases in prescribing opioids. Any doctor in a context of the disease can prescribe opioids. This can be an endocrinologist, GP. So all doctors working with pain syndrome are allowed to prescribe opioids. This is in our legislation. There is a document on prescription and on prescription of opioids within the scope of palliative care. This is, of course, narrowing it down, but the meaning is that in the final stage, in the terminal stage, every doctor can prescribe opioids. Our French colleagues that were dealing with this were really shocked how liberal our laws were. Actually, we can prescribe opioids for 10 days. If the stock is exhausted, we can re-prescribe. There are no restrictions. There is resistance from the health staff who was unable to adapt, but we have a very good legislative basis. If needed, we can send you the documents. There were special forms. The forms were changed, the prescription forms, I mean. First, they were prescribed for 3 years, then a change was made, now they are for 10 days. A big group of specialists is working. Nevertheless, there is this opposition, resistance. There was a period when ministers of health were changing every year. It was a hard time. So we were more resistant than our ministers were. So now we have a very liberal and good legislative basis. We can share it and we can work together. Thank you. Dear participants, please don't ignore this opportunity. If you have a wish and need to study the materials, you can ask us or them. We will provide contacts and they're ready to share their recommendations and materials. And another question, of course, when the minister is changing, it's hard. I'd like to emphasize the success of your strategy once more, because you were able to get in touch, to be in touch with all new government representatives. You mentioned resistance by mostly the health professionals. In addition to the education work in schools, regional visits, people need to be told how it is done, that this is not scary, that this is efficient and needs to be used. Are there any other ways, or do you maybe have plans? How do you plan to deal with this challenge? I already mentioned once that I am an expert in pain and palliative care, the real people, real work. We had tours, we had three tours countrywide organized trainings. But it's not enough to share information. They were doing monitoring. I showed you the 4%, but even those 4% were not there. People were one-on-one with their pain, had to manage it somehow. And even if we train, if there is no audit, meaning no punishment, not a good word, some administrative measures, and coercion, which is a strong word, it's too strong word. But we don't need to leave the professionals, medical professionals, in their comfort zone. They need to get out of their comfort zone and prescribe drugs. There was a meeting recently in the ministry. This is not about the lower level, primary healthcare professionals and family doctors. It's about their leadership. Their bosses, their leaderships are resistant because the administrators don't want to get out of their comfort zone, and it's hard to change something. So we train them, they're ready. The problem is on the local governance level, or head of the polyclinic, head of a regional center. They are mostly resistant because they are within the older paradigm. When we invite them to a training, they send their deputies or other colleagues. I need to tell this because I think there are similar problems everywhere. All heads of clinics, polyclinics referred to police, that there is going to be police control because they are in charge of the illegal drugs trafficking issues. We had workshops with the police. We don't have this problem. They tell the police will come, they will start asking us. This is not the case. And every time I ask, when you are prescribing antibiotics, you are not remembering the police. Yes, of course, it's a valid question. I wish you success, and please, this is a common problem. If you find a way or there is a breakthrough in the communication with doctors on prescription of opioid painkillers, please share it with us. I think we will need to share your experience with other colleagues. We have another question. We are just trying to break through. We are for the third time, for the fourth time. I mentioned when among our challenges is the change of mentality. Some of them are not interested because they are going to retire, so this transition phase is really hard. Yes, sometimes it is lengthy, but we are moving forward. The next question, I don't know if this is a question to you or Eva or maybe Anush. As we understood from your presentation, it's not the entire territory of Armenia, where home visits are paid. So the coverage area of visits is limited. If someone has an opportunity to come to the hospital, they will bring their child or relative, but there are people that don't have this opportunity. An important question, especially in COVID period. Do you have a telemedicine experience? Online consultations, Zoom consultations, or phone consultations? Can you please tell about opportunities and restrictions and how legal or widespread it is in Armenia? I have a personal experience. I consulted patients using different messengers. We have a strategy that if a palliative patient is unable to come to Yerevan, the palliative care needs to be spread equally in the country. Of course, we focus on mobile services because not always a patient can come to hospice, even to hospice. And we know from our experience and the world experience that palliative care is sent to a patient and not the patient always comes to a hospice or palliative care center. As to the telemedicine, I don't think there is legislation, but we use it. Very often patients can't come to our hospital and I use telemedicine. I'll give the floor to Eva so she can add. Thank you for the question. Our mobile services, especially child services, are in the organization stage yet. We start from the pilot model that will serve the capital, Yerevan, and neighboring areas. But when we prove our financial sustainability and the usefulness for the patients and the health staff, we will be able to spread the model throughout Armenia. Of course, we would like to remain as an organizational methodological tertiary center. And of course, there should be services in the regions. Telemedicine is not formal. It is not formalized in the strategies, standards, laws, but in the future, the center that is going to ensure the methodological and technical support will be supporting the regions using modern information technologies, including telemedicine. As Nana Tigranovna told, we are in a stage of informal communication, supported by colleagues, so we can do this using a phone, Zoom, other platforms, but it's not formalized. I'd like to add that there are centers for adults in the regions based on the polyclinics. The patients, so these medical centers are accessible for the patients. There are the so-called district doctors who has also the function of a palliative care specialist. They can provide services locally. So for adults, if there are centers, they are accessible for the patients. Another comment. It was our primary strategy to focus on the primary level, to train them, to make it more accessible for a wider population. We are in the transition phase to electronic medicine and universal health insurance. And it should be mentioned that if we are using electronic methods, I think this is going to be discussed. Thank you for sharing this. We have another question in the chat, and this is going to be the last one because our webinar is close to its end. But I think it's very important, and it is primarily a question to Alisa. It is about hard discussions with the patients and relatives of children and adult patients. Our colleague is asking, do you have your own recommendations? Of course, there are methods, there are methodologies, but maybe you have your own professional tricks, your recommendations, and could you please tell who is participating in these meetings usually? For example, a conversation about the death planning of a patient. I will start from the end. Usually, the doctor and the psychologist participate. Together, they talk to the family. This is in the ideal situation. Sometimes it's the doctor only, sometimes it's the psychologist only, but in the ideal situation, this is the case. There is a golden standard for hard talks. This is the Spikeman protocol, which is clear. There is a certain red line that you can focus on and move on. I can't recall any specific recommendations. This protocol is really good. You mentioned that a spiritual leader or a priest helps you. Does he participate in such talks? Yes, we had a case.
Более духовной стороны разговаривал с родителями, что очень-очень поддерживающе. Да, он принимает участие.
Спасибо, спасибо большое.
На связи, если мы звоним, мы очень просим, чтобы он пришел.
He's always on call when we call him and ask him to come. He does everything to be with us. Thank you very much. Thank you for sharing your experience with us. Before concluding our meeting, I would like to once again thank our distinguished speakers and the team of the interpreters and my colleagues from PACE. And also I want to draw the attention of our lecturers in the first place to the comments in the chat. Colleagues from Romania expressed their gratitude and their admiration for your work. A colleague also, quite a well-known expert in the field of palliative care. I would like to preview that in March, we plan to hold a roundtable with the participation specialists from various countries, Belarus, Kazakhstan, Armenia, Georgia, Lithuania, on pediatric palliative care. And it will be an open event where we will discuss the most difficult problems in pediatric palliative care. And as soon as the exact date is known, we'll announce it. I want to remind you once again that the announcements of our fund can be seen either by subscribing to the newsletter or the mailing list, or by following our social media pages. All of them are listed in the webinar chat. Besides, it's very important to get your opinion about our webinar, to get your feedback. We always try to improve, to make our webinars even better, even more convenient for the speakers and for the participants. So in the chat, we'll provide now a link to the form that we ask you to fill in. If you have any comments, any wishes, don't be shy, please. In any way or form you can connect with, and also tell us about it. Thank you very much for this meeting. Hopefully, we will meet and conduct many more joint events with yourself. And that's probably it for today. Goodbye. Thank you very much to the speakers and to the listeners. Thank you. Bye.
До свидания.